Thank you, MSN, for bringing this molecule to India. And you are actually doing a great service to the nation and to the patient, as well as to the scientific community of India. Now, since the topic is Cangrelor, I'll go directly into the core of the subject. Like when you have ACS or any stent-related issue, you have certain things coming in the field of your stent, is stent-related thrombosis, or in acute coronary syndrome, for example, non-stable angina, non-STEMI, and STEMI. So with the time, as long as your artery is blocked, this cascade keeps on building, starting with fibrin, red cell, platelets. So participation of platelets is very, very early, and it keeps on going. The intensity of platelet activations, aggregations, is very intense in the first few hours. Later on, it becomes a little bit quiescent. Now, what has happened in this world till 2020, as far as the interventional cardiology is concerned? In this globe, there are many new operators, many new imaging, many new drugs, many new stents. But till 2020, in this large nationally representative cohort of more than 51 lakhs of patients undergoing PCI in US between 2019 and 2017, 9 years, the ISR represented around 10% to the total of PCI procedure. About 1 in 4 patients undergoing ISR PCI presented with acute MI, non-STEMI and STEMI. The most common treatment for ISR is DS. By presenting this slide, I want to highlight one thing, that perhaps the stent-related issues, the ISR has not changed, irrespective of the stent design, whether it is cipher, thin generation, ultra-thin generations, cholesterol-lowering agent. But acute stent thrombosis or stent-related death during acute situation has come down little bit, but still it is very, very significant. Now, when you're dealing with acute coronary syndrome, whether that RT to be treated or not treated, whether that one particular antiplatelet drug to be considered or not considered, all depends on the clinical scenario. So there are certain things which are dying down very fast in the field of acute coronary syndrome, the use of physiology. So what we have learned from the FAME trial, we are unlearning now. So there was a time when we saw that these agents are very popular, and till date, this is still the #1 drug, oral P2Y2 inhibitors in the treatment of acute coronary syndrome, whether it's medically treated or treated by a stent. And the benefit is quite substantial, and also has been shown that ticagrelor does reduce the cardiovascular mortality. But it comes with a price, and sometimes it is bleeding. And if you're using clopidogrel, then stent thrombosis can always come as a surprise. So the physiology is taking a backstage, but the newer antiplatelet therapy is coming up with new ideas, and one of them is Cangrelor in the field of inhibiting P2Y2 inhibitors. Now, stent thrombosis, sometimes is so scary and it becomes so messy. And once you have a stent thrombosis in the setting of acute coronary syndrome, actually you are going through the hell. And if you are in hell, you have to keep on going because you have put a stent. So how do you go through the hell in presence of a good oral drug which you have given in the past, like clopidogrel, ticagrelor, Now we have to think something different, like intravenous Cangrelor or GP2B, or a drug which can act very quickly in the future without any bleeding. So new pathway, that is factor 7 inhibitors. So this man who presented with acute coronary syndrome, hypotensive, non-STEMI, LVF, diabetic, he is brought to the table immediately. You can see that large circumflex is chronically occluded. Now, if you perforate this artery while putting your guide wire, and if you have very long-acting oral antiplatelet, and if this man has got multivessel disease with left main, and which you want to do by CABG. So after having an angiogram, you are caught in the wrong foot if you have already loaded them with oral antiplatelet like aspirin ticagrelor or aspirin prasugrel or aspirin clopidogrel. Usually the surgeon, they don't prefer this antiplatelet and they delay the surgery. And suppose this angiogram was normal in many cases, this patient has to be sent for further investigations like your gallstone. And this acute cholecystitis patient, usually they wait for a few days in the hospital. That incurs a financial loss, agonies, and some complications due to non-cardiac causes. But now we have something in our hand, like if you give something which is very quickly acting and very rapidly disappearing, these make our life very easy. So in 2022, I have a very low threshold of using Cangrelor in the setting of acute coronary syndrome, even in chronic stable angina, for doing ad hoc angioplasty if patient can afford it. So what is new in 2022? That IV Cangrelor and imaging. Imaging means you have to do a good job with the stent expansion by doing OCT or IVUS, and you have to give PCSK9 inhibitor followed by other therapies. Now, in spite of its strong data, PCI and platform stop for futility. So PCI with IV Cangrelor in platform was done, and when they saw there is no difference between Cangrelor and clopidogrel, they stopped the trial prematurely. But was this the death nail on Cangrelor? No. Why? Because in this trial, the definition of MI was a problem. So when they re-clarified or re-evaluated the definition of MI, and they have used Chi definitions 3 times upper limit of normal of CPK-MB, what they have shown that Champion Phoenix is a large trial which shows death, MI, revasculation, and stent thrombosis reductions. And from there, we got the idea that perhaps this is the drug in selective cases. In selective cases where there is a chance of clopidogrel resistance, or is a chance of sending this patient to surgery, whether if you have too many stents already there, and you know this case is a potential surgical case or potential non-cardiac case, there you can use a Cangrelor for rapid onset and offset of actions. When GPI was discovered and tested, tried in acute coronary syndrome, Eugene Braunwald told us that it's a breakthrough in thrombocardiac science. And now it has disappeared from the market because of its side effect. So this Cangrelor is absolutely without any long-term side effect, and perhaps there is a mortality benefit, death benefit at 48 hours and at 30 days. So GPI like Riopro or Inticlidin, the fast onset, fine, but it takes minutes. But Cangrelor is also very fast acting agent. Potent platelet inhibition, absolutely both are equally good. One is long-standing, long duration of actions. Other one is very short acting. Rapid onset, it works within few minutes. A rapid offset, it reverses within few minutes. And once you give GP2B3 receptor antagonist, most of the surgeons, they decline to do an CABG because of bleeding. If you have a CKD patient, it comes as a surprise on the table. And if you use GP2B3 receptor antagonist, perhaps you have some problem of bleeding, not only your retroperitoneal intracranial bleeding, the access site bleeding, especially with femoral without any closure device, also increases. Though that has come down with the usage of radial angioplasty, even then, those who believe in femoral root or those who use a large bore device for access in the coronary, that may be a problem. Now, with time, the gap between treating this patient, bringing them to the truth of table, that is cardiac cath lab, and pre-treating them or stabilizing them with fondaparinux, enoxaparin, statin, aspirin, clopidogrel, etc., has come down significantly over the decade. So PCI cured 6 days, RETA 3 days, to proceed 23 hours. And we know that Euromax Vivaldi 50 minutes and Champion platform 7 hours. So the gap between the initiation of oral therapy, taking them to the table of truth, doing the angiography, fixing the coronary, or discharging the patients from the hospital has come down, as the strategy has changed very significantly. So if you give anything with a bolus from your femoral puncture sheath, you know that his antiplatelet activity on the top of aspirin is 100% within few minutes. And as long as you continue, you are sure that your antiplatelet activity is continuously inhibited or continuously persisting. So you have to check that the intravenous line, which is having a continuous flow cannula that is running. So that is only the disadvantage of having any drug which has got rapid onset and rapid offset of actions. So ensure that your IV drip or the pump is running properly. Give 30 microgram per kg per bolus, followed by 4 microgram per kg. So 60 kg, 60 into 3, 1.8 ml, 80 into 3, 2.4 ml of Cangrelor. Ideally, it should not be mixed with the same line, should not be used for like NORADs or Vivalodin or Argotramal like drugs. It should be a separate line, and it can go with normal saline. So dilute it and give bolus, then followed by your intravenous infusion. And there should be overlap of half an hour with your choice of antiplatelet, and most of the time it is ticagrelor. Now you continue for another half an hour, then you stop the infusions. If the patient is vomiting, still continue, and once they are stabilized, able to take orally, eating well, and then you can give the loading dose. So as long as your IV Cangrelor is running, you are sure that he's not going to have a acute stent thrombosis like phenomena due to lack of antiplatelet activity. Now, there are issues with acute patients for any any hospital, any physicians. Like, you know, these people are sometimes very sick, that mechanical, they are on mechanical ventilations, vomiting, they're in shock, the absorption is not guaranteed. They sometimes get sedation from outside. They are on therapeutic hypothermia after cardiac arrest. And we also know the pre-treatment often delays, as I mentioned. And the pre-treatment has not worked, especially with oral drug. But pre-treatment with intravenous Cangrelor on the table just before starting your procedure will work. and I'll tell you the data. So there are more negative trials in support of pre-treatments than favoring the idea, like your many trials like Aquas trial. Large current oasis 7 PCI, 600 milligram reduced 14% MES and 46% of stent thrombosis. So clopidogrel will be there, ticagrelor will be there, prasugrel will be there. But clopidogrel resistance is not going to go away, and especially in Indian patients and Asian Indian patients, they have more clopidogrel resistance than European and American patients. And sometimes because of anxieties, morphine, fentanyl, etc., these sedations can also cause, or if they're very sick, their gastric motility may be delayed. So this medicine remains in the stomach and they're not absorbed. So there may be chance of not only acute stent thrombosis, but slow flow, no flow phenomena could be due to your lack of antiplatelet activity. Previously, from the GPI knowledge or GP2B3, GP2B, this RioPro history, we have understood that if you give intravenous integrinin or RioPro, the slow flow or no flow phenomena disappears. So we also know that anything which is quite suspicious on your implanted stent, anything like tissue protrusions or angiographic suspicion of stent thrombosis, you did not hesitate to give GP2B, but now you are not prescribing GP2B because of bad legacy it carries, and many people lost their life. Many patients lost their life because of retroperitoneal bleed or intracranial bleed, the need for blood transfusion. Whether that gap can be overcome by ticagrelor prasugrel, yes, to some extent, yes. But if you see the activity of crushed ticagrelor versus your Cangrelor, even there is a lag, and you know that morphine or as I mentioned, other drugs which can delay the gastric motility, the gap widens, and sometimes you are not sure whether the patient has received clopidogrel, ticagrelor, what time. So those kind of confusions or cross-checking in the middle of the night is very difficult. So you know that this information sometimes can give some confusions. So you can switch from one molecule to another if you really want to do on the top of Cangrelor. For example, if you have given Cangrelor and you're continuing Cangrelor, now we want to give clopidogrel, you can give after half an hour. There's no procedure in my hospital done on clopidogrel. If it is acute coronary syndrome, all are done with ticagrelor. So you load them again. If you have a confusions, giving just another 2-3 tablets is not going to do harm. But if you have a stent inside, and if you're not sure whether he has received a treatment of oral P2Y2 inhibitor, definitely will cause havoc. Now, off hours PCI and on hours like daytime PCI in our day-to-day practice is also different. In the on-hour PCI, you have a lot of people who can take care of this patient, their creatinine, whether he has received the drugs in the middle of the night, you're not sure. You don't have any time to call somebody because in the middle of 2 o'clock, it may be a problem. So once you give them Cangrelor, you're sure that as long as you continue, sometimes 2 vials is required, and you're sure that your patient is protected. Whether you give prasugrel ticagrelor, in this kinetics, in this zone, first 2 hours is a kind of blind spot. This blind spot can be covered by intravenous Cangrelor, which can never be covered by any oral therapy, which is not a rocket science to understand. So this delay in onset of action is the advantage of Cangrelor. So 1 hour DPD, and as you go with the time, and once you finish the procedure, even at 6 hours, there may be some people who do not show the full-fledged effect of platelet inhibitions with prasugrel and ticagrelor. So this is the situation where you can overcome by giving intravenous Cangrelor. The first 2 hours may not be crucial for some people because maybe they are stable, but the first few hours may be too crucial for some people who are really sick, multi-vessel PCI, multiple stented, slow flow, no flow. And these first 2 hours, stent thrombosis, death, and ischemia-driven revascularizations, the occlusion of the side vessels can be reduced by usage of Cangrelor. So in last few months, I have used around 40 cases, 40 patients with IV Cangrelor. I have not seen any side effect, and I did not see any large bleeding, massive bleeding, requiring blood transfusions. I have not seen any stent thrombosis. And the incidence of slow flow, low flow, or a no flow like situation, I have not seen, but this may be anecdotal. So yield of Cangrelor and ticagrelor loaded patients, again, is quite significant within first few minutes. And as you see at 4 hours, almost 100% inhibitions of platelet. Now, these cross ticagrelors, we also used to practice when this was not available. This is kind of alternative when you see that these patients are getting ticagrelor in front of you. They're chewing the tablet, you're sure, you ask the nurses whether you're giving ticagrelor or not, and you can assure that patient is receiving. But if you see the difference, even in this group, this blind spot is occupied by a Cangrelor. So this is the time zone, first few hours, may not be very significant for a long-term outcome, but on the table, you finish this case sometimes within 15 minutes, 30 minutes, you go home, and you are not sure whether this patient is protected or not. So this protection usually comes from a very, very robust antiplatelet, that is IV Cangrelor. So the pre-treatment gap, early treatment gap, a crushing gap, and if sometimes they vomit, if he vomits, that he's already on a run of IV Cangrelor. You can repeat the dose of oral therapy once you have finished your angioplasty. You can always come back to the ICCU. And it has replaced the usage of GP2B3 receptor antagonist. The usage of GP2B3 receptor antagonist in Champion Phoenix only 3.5%. So 54% in Triton Prasugal, around 30% at ticagrelor. And this is bad. This is evil. This is death. And this is basically translates into more negativity than positivity. So that Cangrelor can cause extinction of GP2B in 2022 if you use in almost all patients of acute coronary syndrome, where you see that there is a chance of patients are developing some PCI-related complication, flow-related or stent-related, thrombotic, pre-thrombotic, which can be seen sometimes, which cannot be seen, which can be predicted, sometimes cannot be predicted. But if you have very complex patients, very complex situation, you can rely on IV Cangrelor. Based on this Champion Phoenix trial, it has been prescribed, it has been adjudicated by FDA. There are some people who voted against 7:2 as a class 2B. GP2B was class 2A. So because of the hitch in the Champion platform and other trials, and not much of great difference between, with clopidogrel, this is still class 2B. But who benefits the most with IV Cangrelor? As I mentioned, when it is a surprise, like the normal angio, and you have pre-treated them, then suppose he's suffering from gallstone or acute duodenal ulcer, clopidogrel-resistant patient, those who are having leg pain, severe calcification. It also reduces the cost of GP2B, which is much higher than your Cangrelor. Now it is affordable, very attractive solution. And the benefit is sustained up to 30 days. And it's quite intuitive in cheap cases, like as I said, if you're having too many stents and take a long time, and if you're not sure whether the CTO will cause perforation or not, and you want to hand these patients of CTO to your surgeon, and you can reverse your heparin if you're not putting stent, But once you give clopidogrel or ticagrelor in CTO patients, or if they bleed due to perforation, it can be catastrophic. But if he is on a Cangrelor in CTO, it is sometimes quite forgiving. Some people say that nowadays the intraprocedural stent thrombosis is very rare, but if it develops on the table, you can go for thrombosuctions, you can go for post-dilatation, etc. And these thrombus, once they start forming, a thrombus begets thrombus, and the CPK-MB or paroperative or procedural enzyme elevation is havoc. And you know, this procedural enzyme elevation is much more serious issue than spontaneous MI. Now, any trial you do, you have some criticism, like why they didn't try a more potent oral antiplatelets like ticagrelor or prasugrel, why clopidogrel was used in Cangrelor, a champion series, champion like platform and Phoenix and PCI. You can argue in favor of that, but that was the standard of care when these drugs were tried, when this trial was done. The timing of clopidogrel is also sometimes an issue. With that, I will come to champion trials. It is basically multinational, multi-ethnic, multi-centric, and that includes India too. Larger number of people in Phoenix, you understand that 10,000 patients, 8,000 patients, 5,000 patients. So STEMI is missing here, P2Y2 name. So these are all comer patients, Phoenix trial, like routine angina, STEMI, non-STEMI patient. Clopidogrel is the comparator. Champion PCI, STEMI patient. So these baselines, STEMI and non-STEMI, and these are not different, but out here, the STEMI patients are excluded. And this is a negative trial. And you know, this clopidogrel 600 milligrams, sometimes 300 milligram is given. Then your maintenance is going on. So what you see in this trial, the timing of clopidogrel varies within 30 minutes before PCI, end of the procedure, unclear, 30% after PCI. So that means for the first 30 minutes, patients were only on your placebo and aspirin, no clopidogrel. So that could be one of the factor for other arm to be weak. Bioavailable use was 18% here. Death rate 0.1, very low death rate, because the imaging, the technique, the technology, the stent has improved over time, and we know how to do it. Stent thrombosis rate has come down because we do not put BRS, we do not put cipher-like stent, or taxes, the horrible historical mistake we do not do about choosing our stent. The definition of per procedural MI, it reduces by 0.58%. So this per procedural MI by sky definition is reduced by using IV Cangrelor. And there is a difference in the stent thrombosis. And if you see, these people are very elderly people, diabetic people, stable angina, or majority of them had non-STEMI. STEMI is around 12% here. So 300 milligram, 600 milligram, 90% of 600 milligram, 56% pre-treated, during PCI 30%. So almost 40% patient did not have any clopidogrel in the first few hours. And what we have seen, that intraprocedural stent thrombosis is 48 hours and in 1 month in Phoenix in 10,000 patients, very significantly, robustly, with a very significant p-value at the death MI, ischemia-driven revascularizations, ARC deficient stent thrombosis, definite. So this is quite significant observations. And if you see on this graph, that graph is separated quite nicely from the very first few hours up to 48 hours with a relative 84. As far as the death MI, ischemia-driven revascularization, stent thrombosis within 48 hours, also at 30 days. So this is quite significant, and you also know the 30-day mortality. So these are very small number of people, small number of events, which separates them, but maybe statistically significant. But the people who have died, or people who develop thrombosis, maybe 100% for them. So now the thing has improved so much. The stent difference between one stent to another stent is very difficult to demonstrate, and the stent thrombosis has come down to a single digit and less than 3%. So it's even a small difference with the outcome by a drug which is affordable, which is attractive, which is available now, should be tried in our patient. Why should I give a chance to the patient to develop even one person, one stent thrombosis, doing 1,000 angioplasty? So you have to treat more. So maybe this is the only drawback of IV Cangrelor, to have very small benefit, but the benefit, there will be there, the number you can debate. But those who develop the stent thrombosis, those are that still regrets, those who develop bleeding still regrets of doing primary angioplasty. And these people, if they die, there's the biggest regret in interventional cardiologist mind. So these regrets can be reduced. The death is always sometimes preventable, or there are many methods which can be reduced further by not only your drug, your device, sometimes other therapies. Polypharmacy is also important. Good care, ICU care is important. Arrhythmia care is important. So choosing a drug is very of paramount importance, whether putting a stent or not. Now, whether you can give medically treated patients, if you're not able to decide about your putting a stent, these patients should continue IV Cangrelor, but that will be a very strong propositions, very high cost proposition. Those who are requiring a stent, these are the people they should receive IV Cangrelor. Numerically, there is more benefit in chronic stable angina with very tight confidence interval, 0.63 to 0.95. In non-STEMI and STEMI, the confidence interval is on the other side, wrong side. But the graph from the line of unity is always on the left side. So the stable, non-stable, it benefits, whether biomarker positive, either male or female, white or black, it gives its blessing. So, ladies and gentlemen, I think almost we're coming to the end of my talk. If you go to the meta-analysis of 24,000 patients, efficacy, the stent thrombosis, though it is very little, but in my mind, it's very significant. Maybe one or two, but for those who died due to stent thrombosis in placebo, it is a regret, and ultimately QMI, spontaneous MI, translates into long-term LV functions, LV dysfunction, or heart failure. So there is no doubt in my mind, if you use this molecule in a special situation, in selective cases, those sick patients do benefit from IV Cangrelor, 30 microgram followed by 4 microgram. So these are data available. There are some limitations, some criticism of this trial. Whatever way you do, there will be criticism. No trial is a perfect trial. But I see the best use of Cangrelor in recently when somebody is on recent drug-eluting stent and he develops some fracture, or he requires an appendix surgery, or like an accident, he requires immediate surgery or neurosurgery. So these are the people where your oral drugs like clopidogrel, prasugrel, Ortical can be stopped confidently. They should be put on IV Cangrelor. As long as IV Cangrelor is there, there's hardly any chance of stent thrombosis. You can discontinue aspirin once you are fixed the fracture or your gallbladder or your appendix. You can continue for some more time. Once you are comfortable, then switch on to oral drug of therapy. So bridge is very, very nice idea, and you have this beautiful drug which can work on wonder, and you can reduce the bleeding. So in these people, you have a very good choice of having a molecule which has got very rapid onset of actions and very rapid offset of actions. So to summarize then, if you have patients who is suffering from coronary artery disease, And if you have a problem with clopidogrel resistance, if you have a patient who can afford it, if the drug is available, that should be used in most of the cases. But I'm not saying that it is a mandatory. If you think it is wise to start, if you think it is wise to prevent stent thrombosis, acute stent thrombosis, slow flow or no flow in this group of people, which will be translated in the reductions of major adverse cardiovascular events, stent thrombosis, not only at 24 hours, not only at 48 hours, but also at 30 days. So this molecule is now available in India. I would suggest that give it a try. It is not at all a harmful molecule, rather a very useful molecule, very effective molecule, very safe molecule, and it does translate into reduction of death. Thank you.
Yeah, thank you very much, Dr. Hazra, for such a nice and informative talk on Cangrelor. Now, Dr. M.P. Tripathi has also joined. So I asked Dr. Tripathi to share his opinion and feedback on the first oral P2Y12 inhibitor, that is Cangrelor, and to initiate the question and answer session of the delegates.
Okay, thank you, Dr. Hazra. I think you have covered most of the uses of Cangrelor. I think, to me, I think it is because of its pharmacokinetics and dynamics. It's very rapid onset of action and also rapid onset of action. I think this should be isn't and should be used in I think particular special or individualized situations, and most importantly, what you have mentioned in complex coronary interventions, one, and maybe this bridging. And another indication, maybe I think you have touched, maybe in patients with out of the hospital cardiac arrest because of ACS. And there are also trials which are going on to compare with Cangrelor versus Tripathy, that is a DIABETIC shock MI trial, where Cangrelor versus Tripathy is going on. So, as you know, the results are primarily from Champion trial, where clopidogrel was used. So it may be difficult to deduce the outcome from this trial, because more potent drugs like clopidogrel, like ticagrelor and parsabital, was not used. So whatever maybe, I think it has to be individualized, and most of the cases, I think, as you told in the bridging agent, I think this is life-saving, and also in patients with high-risk patients, this is life-saving. Thank you. So there are some questions. So the first question is, can heparin be used with Cangrelor? I think it is yes, because Cangrelor is an antiplatelet drug and heparin is anticoagulant, and anticoagulant heparin can be used with the same dose in patients with undergoing PCI, either ACS. So any opinion from Dr. Hazra?
Yeah, as you have rightly mentioned, that we are dealing with antiplatelet, we are not touching the antithrombotic part. Antithrombotic part will be your choice. But my intuition is whether in future we can reduce the dose of heparin from 100 units per kg to maybe 70. So those has to be tested in the trial. But for the timing, choice is yours: heparin, bivaludin, arbutraban, whatever you want to use. Please use that. And on the top of that, aspirin plus ticagrelor followed by ticagrelor. Aspirin, Cangrelor followed by ticagrelor.
Okay. And another question is role of Cangrelor in bridge therapy. I think that you have mentioned. Can Cangrelor be given with patients who are preloaded with antiplatelet or clopidogrel?
Yes, as I said, if you are not comfortable, if you have some kind of apprehension of clopidogrel resistance, and you want to switch to a stronger oral antiplatelet, which has been shown to reduce the cardiovascular mortality, like ticagrelor, you can always go for ticagrelor later on. Like patient who has got clopidogrel, you can go to ticagrelor or prasugrel. Patient who has taken just one tablet of ticagrelor, you can give them full dose of ticagrelor. Patient who has taken prasugrel, it is usually not prescribed without knowing angiogram, so that is a mistake. You can continue prasugrel, no harm. But clopidogrel to ticagrelor is the usual practice, or clopidogrel naive patients, those who have not received anything. These are the ideal patients, those who benefit from IV Cangrelor. So both way, if you are drug loaded with clopidogrel, you can switch to ticagrelor, or you can continue clopidogrel also. If you have given 300 milligram, you can give another 300 milligram, or if you have given 600 milligram, you just continue oral tablet.
And then there is I think there in pharmacodynamics, there is a I think if you use clopidogrel and prasugrel along with Cangrelor, the efficacy of Cangrelor comes down. There is a drug interaction. So that is there in the, I think, in the drug literature. So whatever may be, if the patient is preloaded, because I have less experience with this agent, so he can give better, I think, opinion.
Like most of the situation, these patients are preloaded with clopidogrel, and I switch them on ticagrelor straight away for all ACS patients in the last 10 years. So ticagrelor is my preference. So maybe I'm biased towards ticagrelor, but this is backed by many observational study, randomized clinical trial like Plato trial. And if somebody has not received, there is no question that should be covered by ticagrelor. If somebody has received only 2 tablets, I just give them 1 more tablet on the table, half an hour continuation of the infusions, then you can stop.
Okay. So another question is, can GP1 GP inhibitors and Cangrelor can both be given together? I think
yes,
no.
2.5% of patients in the Phoenix trial, they have used GP2B3 receptor antagonist with your IV Cangrelor. But as I said, if you start using Cangrelor, perhaps you will not require GP2B3 receptor antagonist at all, because this is 100% inhibition of platelet within 3 to 6 minutes of initiations of bolus therapy. So you're not going to get 1000% of inhibition. It is almost 100%. So 101% is not a possibility with GP2B3 receptor antagonist.
Okay. Another question is whether it can be used intracoronary.
Oh, why should I use intracoronary when intravenous access is there in front of you? You have a sheath, you have, I don't know. I mean,
maybe he may be thinking regarding the slow flow or no flow situations, whether they're in experience or any case studies like that.
No, these are so rapidly acting. Once you give intravenous drug, it reaches heart within a few seconds.
So another question is when to switch to ticagrelor or clopidogrel after using Cangrelor during PCI.
As I said, once you finish the procedure, you have shifted the patient to the ICU, continue for at least half an hour there, and ensure the patient has received your drug at least half an hour before. So half an hour to 1 hour, I would say, is the ideal period when you can confidently discontinue. So in our situation, you don't go by this clock usually. Once they go to the ward, I told the sister at least half an hour, because he has received half an hour in the cath lab. You know the timing, but in the ward for half an hour it continues, then you stop.
Okay, then maybe there is I think I have no more questions. So what are one question is, will it be helpful in complex PCI? I think that you have covered. So I think it has got a definite advantage in patients when you are taking for complex PCI, what you have enumerated. I think this is a situation where this can be selected, this has been. And regarding this starting of the drug or your P2Y12 inhibitors, oral agents, maybe ticagrelor can be given at any time during the infusion. Clopidogrel and prasugrel has to be given after discontinuation of Cangrelor. So Any question? I'll just find out any more question.
Amit, anything else?
No, sir. I thank you once again for such a nice talk. And I thank Dr. Tripathi also for chairing and moderating the session. Before we close the session, I will just take a few minutes of time. So, Doctor, in MSN R&D Center, India's Ticagrelor was first conceptualized. A team of scientists developed the process for making Ticagrelor. Core team with years of struggle manufactured Ticagrelor in India, starting from pilot batch to commercial batch, and now our TRA is manufactured in USFDA approved plant. So, MSN antiplatelet range includes TRA, that is our Ticagrelor 90 milligram, TRA kit, that is a combination of Ticagrelor 90 mg plus aspirin 75, and Canreal, this is the P2Y12 IV inhibitor. So, doctor, we may be the young player, but our drive and enthusiasm are the best in associating with you. So, with this, I thank you all for attending the webinar. I thanks Dr. Hazra. I thanks Dr. Tripathi for chairing and moderating the session. Thank you all.
Thank you. Thank you. Allapa?